All right, so let's talk about sodium. Sodium is the most abundant cation ion in the extracellular fluid, right? We did that with the salty banana. Some properties and functions of it, it attracts water into the extracellular fluid, as I just showed you in that last case. Okay? It also deals with nerve impulses and muscle contraction, which you've learned from A&P1, so I'm not going to bore you with that, amongst other things that sodium does. Now, hormones that affect sodium, this is a good review for you guys. We learned that aldosterone is going to reabsorb sodium, right? Good old days. All right, like I said, start studying for that final exam. If these words don't make sense to you, now's the time to do it. Carpe diem. Okay? We also learned, well, we will learn about estrogen. Estrogen is similar to aldosterone structure. Okay? Estrogen is similar to the structure of aldosterone. So because of that, it's going to reabsorb sodium. We'll learn about the menstrual cycle. And there's certain times during a menstrual cycle we're going to give off a lot more estrogen and you start retaining fluids for that reason. You start feeling bloated. Women start feeling bloated because of this extra sodium that gets reabsorbed. Cortisol. Ooh, remember that one? Comes out. Where does cortisol come from? The adrenal cortex. Okay? And this is also going to reabsorb sodium to cause, and when you reabsorb sodium, blood pressure goes up, right? We just dealt with that. ADH. ADH, it's released when there's an increase of sodium in the blood. If there's more sodium in the blood, then that's going to make ADH reabsorb water. All right? And we also have AMP, right? Atrial natriuretic peptide, also referred to as ANH, which is atrial natriuretic hormone. And this comes from the atrium. When the atrium of the heart picks up that there's a high blood pressure, AMP comes out and it's going to block aldosterone from working. It's going to inhibit it. And that's going to stop sodium reabsorption. Okay? So these are hormones that affect, in one way or another, sodium. Now, we have a condition called hypernatremia. That's where the Na comes from in terms of sodium. Natria, some Latin word, right? But this is saying that there's an increase of sodium in the bloodstream. Okay? If you increase sodium in the bloodstream, then water is going to increase in the extracellular fluid because it comes out of the cells and it goes into the bloodstream. By way of that case I gave, case number 2, right? If that happens, you get hypertension. And you've learned, too, that if you have hypertension, you've got a greater hydrostatic pressure, blood is going to be forced into the interstitial area, and it's going to cause edema. Okay? So with hypernatremia, you will have hypertension, you'll have muscle twitching, mental confusion, and coma when you have this much, because it affects also the brain. And again, going into all the detail of that is too much right now, but it bridges what you learned in A&P1. Then we have something called hyponatremia. This is a decrease of sodium in the bloodstream. When you have a decrease of sodium in the bloodstream, therefore you're going to have a decrease of water in the blood. Water will leave the blood to go into the tissues. And when it leaves the bloodstream, you're going to have low blood pressure. Does that make sense? You get hypotension. And when the person stands up, he or she will probably faint because you don't have that blood pressure to kick it up. So you get hypotension, and your heart is going to pump faster. The heart rate will go up, trying to counteract, to push, to get that cardiac output back up. So you're going to have tachycardia. End up also having some sort of muscle weakness, again, where the sodium affects the muscles. So let me just say one thing about edema, putting this all together. There's only 3 general causes for edema. Congestive heart failure, something to do with the heart itself. That's going to increase venous pressure, and that's going to increase jugular venous pressure over here, and can cause pedal edema. And you do that. Remember, we talked about if you need to go back to congestive heart failure. If you have right congestive heart failure, you're going to have the blood backing up in the jugular veins over here, and also the edema that's going to go down to the legs. All right? Go back to that so you understand it. If you have liver disease, you can't make albumins. Right? Albumins are those proteins, which means you lose oncotic pressure. You lose pressure or fluid going back into the bloodstream because you don't have the proteins there. So you decrease the oncotic pressure, and the fluid stays in the tissues. And this causes edema. If it's due to the liver, the edema starts occurring in the abdomen specifically, and they get this really pot belly. We call it ascites. It's when fluid is in the intraperitoneal cavity. It flows there. It's basically edema of the intraperitoneal cavity, or the abdomen. And the other way is kidney disease. If we can't make proteins, that's liver. If we lose a lot of proteins through the kidney, because you have kidney disease, then that's also going to cause edema. See, proteins are a key thing here in the plasma. If you can't make them, you don't have proteins in the bloodstream. If you lose the proteins, then you don't have proteins in the plasma. Either way, you're either not making them or you're losing them. And if you have something called a nephrotic syndrome, which is basically a certain kind of kidney disease, you're going to decrease albumin in the blood because they're going to be going out, the albumin or the proteins are going out into your pee, your urine, and that's going to also decrease your oncotic pressure. But the way this works is it doesn't just stay in the belly, all this fluid. It actually goes throughout your whole body, and you get edematous throughout your whole body. You look like the Michelin Man. All right? You know the Michelin person over there. He's got like tires. He looks like a marshmallow. And they have something called anasarca, which means whole body edema. The whole body gets edematous. It's not just your belly. It's not just your legs. It's the whole body, the face, everything. But now let's talk about potassium. Okay, potassium. Just a few features about it. Potassium. Whoops, this on. So potassium is the most abundant cation inside the cell. And remember, keep in mind of the salty banana that we always talk about. All right, the most abundant cation outside the cell is going to be sodium. Some features, properties in general. It attracts water into the intracellular fluid. So we're going to talk about that, how that's going to affect things, and how it will affect the action potential. You learned about in A&P1 how much potassium and sodium is going to deal with muscle contraction and nerve stimulation and all. Okay? And there's really, we talked about major hormones that some way or another affect sodium. But here, there's only one major hormone that's going to affect potassium, and that's the good old aldosterone. When we increase aldosterone in our bloodstream, it's going to excrete potassium. Keep in mind, it also reabsorbs sodium. Water is going to follow the sodium. But for potassium, aldosterone is going to excrete, aldosterone is going to excrete the potassium. Now, we got to talk about we have too much potassium versus too little. Now, there's a condition called hyperkalemia, and the kalemia means, the K-A-L refers to the potassium. That's where the K comes from in potassium. If you want to learn about Latin or Greek or wherever that came from, that's what that is. So, what this means is an increased amount of calcium, cal, I'm not calcium, potassium in the bloodstream anemia. All right, so that's what that's saying. Now, this is what most people, if not all medical professionals or non-professionals, we think that if potassium is extremely high, or not even extremely high, just high in general, that this is probably the most dangerous electrolyte imbalances that are out there. Okay? The other ones will, but this one, even if it's slightly high, it will cause big mayhem. So think about what's going to happen here. If we increase potassium in the bloodstream, i.e. hyperkalemia, then that means there's a decrease of potassium leaving the cells, right? If you have too much potassium outside the cells, then think of diffusion. It's not going to go from a low concentration to a high concentration. So therefore, the potassium wants to stay within the cell. It can't go out where there's more. Think of, let's say, 5 potassium in this room and 50 potassium outside the room. The potassium is just not going to want to leave the room because there's too much out there. So the potassium stays within the cell. So therefore, inside the cell is going to be more positive. Potassium is going to stay in there, which means that the action potential in there, whether it's nerve cell or muscle cell, is not going to repolarize. Remember what repolarization is? It's when the potassium goes out of the cell, thus making inside more negative. That's repolarization. So the action potential won't repolarize, therefore you're not going to get another muscle contraction, right? CTX is contraction, all right? So that's what's going to happen here. The problem is, when you're thinking muscle, most people are thinking this, but when I'm thinking muscle, I'm thinking of your heart. Therefore, you're not going to have another contraction of the heart, and you'll have cardiac arrest. This is what we're concerned about with hyperkalemia. You'll get elevated T waves, so if there's a slight increase in potassium, we will see it, we will recognize it on an EKG, and the person will have some sort of muscle weakness. So this is what we're concerned about. Now, we also have hypokalemia, and this is a decrease of potassium in the bloodstream. And what happens here is that you do get some cardiac arrhythmias, but they're not so severe to cause a cardiac arrest. The person will say, geez, I'm feeling some palpitations or something's happening, but it's not as severe as cardiac arrest. Their T waves on their EKG appear flattened, so they're more like a horizontal line. You do get some muscle weaknesses, sometimes cramps. And you also have to, they usually also get constipation. This is really because it's dealing with the smooth muscle disturbance around the intestines. Keep in mind that if this means that there's going to be more potassium leaving the cell because there's less out there in the extracellular fluid, then what's going to happen is it's going to affect more of the smooth muscle. So it's still muscle around the intestines. Therefore, the smooth muscle is just not contracting as much around the intestines, so the food tends to stay in that area for a longer amount of time, thus giving you constipation. All right? You would not see hypokalemia, and they would have diarrhea like, their stool's just coming out all the time. It tends to be a little bit slower. So this is a nice little chart to put this all in perspective. Basically what's happening here, here's normal kalemia. In other words, if a person has normal amount of potassium inside the cells and outside the cells, then you're going to get a membrane potential that should be adequate. Okay? But if we actually increase the amount of potassium outside the cell than inside, thus hyperkalemia, then what's going to happen is that there's going to be less diffusion of potassium going outside the cell. Because it can't do diffusion if it's going to go from a low concentration to a high concentration. So therefore, there's going to be an elevated resting membrane potential. That's what RMP is. Resting membrane potential that's going to be inside. So therefore, it's not going to repolarize. it's going to be higher than usual. If your resting membrane potential is normally supposed to be 70 millimeters of millivolts, all right, it should be negative 70 millivolts. Now there's going to be more potassium inside, so therefore it's going to be more like, let's say, 60, negative 60. It's going to be more positive. So therefore it doesn't need that much more to reach threshold. So it becomes more excitable inside. And that's what's happening with this, okay? In a person who has hypokalemia, there's going to be less out there, and theoretically there isn't going to be much change. However, there is going to be a faster rate of the potassium leaving the cell to the outside over there because there's such less potassium outside the cell. And in these cases, the cells are less excitable. Since there's more potassium leaving, the resting potential is not negative 70, it's now lower because more potassium, more positive went out. So now it's like, I don't know, let's say negative 80 for that matter. So now it's got to get more, it has to now go from negative 80 to negative 55 to actually reach that threshold. The threshold is negative 55, okay? So that's a little bit of review for you on this. Again, action potential, make sure you understand that. That's old news from A&P1. That's where I'm trying to bridge this together. But we did talk action potential when we did the part.